we were good. And of course, they got best to thank you. So, Dr. Dembi has a very busy schedule. This was a last minute. Have a seat, guys. This is really last minute, and if he's a big supporter of diaspora coming home to support to meet some of the unmet needs in respect to some of the gaps. And he said, you know, and the chairman as well. With all my busy schedule, I'm going to make sure I get there to talk to your membership. And again, Dr. Dembi, thank you for being here with your busy schedule. I know you're here. Would you like to talk to us briefly? Yes. Thank you. Please, Dr. Dembi, give a big round of applause to Dr. Dembi, please.
Before Dr. Dembi speaks, I would like to you to limit your questions. But we're not going to spend the whole night. You can write some of the questions that you think we should be addressing, and I can forward it to him. Let's listen to him and hear what he has to say about healthcare and the system in Sierra Leone.
Thank you, sir. Thank you very much. How much time do I have?
I wouldn't 2 minutes, but I'll give you as much as.
2 minutes.
No, but I'll give you as much time as you can talk.
20 minutes.
20 would be.
No, this is, thank you very, very much. This coming home, I must start on a rather sad note. We're touched, hurt, and very concerned about what happened to our brother and friend, Dr. Rogers. Dr. Rogers went to Sierra Leone, and I urged him, and I urged everybody else to just do their best for Sierra Leone, and to go back to Sierra Leone and not go small, try to go big and make a difference. And he heeded that call and came home and actually rallied one of the biggest teams that we've seen come out of Sierra Leone. He went out and they worked in Lunge, they worked in Makeni, and he insisted that they go work in Puja as well at his home. We're sad that he had Dr. Leone was there and everybody was there, and we're sad that we lost him in that mission. And it's really sad, and I feel bad for him. I feel bad for the family. I feel bad for the organization that was there. But I think there's a feeling that there's a God. There's a God that determines and sees things that we don't see. Yeah. What is people die here? People die here in the US. People die everywhere. Yeah. But he went to Sierra Leone to do what he loved to do, what he spent his whole life doing. And he went home to his village to provide services for his people. He died doing what he loved to do. And for that, we would say, thank God. Say thank you to his family. We thank you to the organization for sharing him and his life with us in Sierra Leone. So we've all heard there's a lot that could have been done that was not done. But know that it's the will of God. People die in America. Doctors die in America. You know. So again, we just have to be a little careful about how we frame these discussions. And so I walked into the discussion about cardiac diseases and coronary heart diseases in Sierra Leone, and I was a little concerned because the conversation stopped at a cliffhanger, citing what was not there, citing the problems in Sierra Leone, citing the challenges and the difficulties of going back to Sierra Leone. That is very, very important to catalog that, to highlight that. But the next critical question is, what are we doing about it? What are we doing? Who's going to do it? These are the brightest brains and brightest minds in Sierra Leone that came over here. It's the Queen that has moved over here. If we want things done, we have an obligation to go back and help catalog those problems, but also offer solutions as to how we're going to solve these problems. So I was here, I worked for the US federal government for 42 years. I live in Potomac, Maryland. I dropped everything to go back home to Sierra Leone. I would recommend that for a lot of people, but it's not for everybody. Because it's a big sacrifice to go back home. But the good thing about it is you're able to see the problems and you have an opportunity to do something about it and change the narrative. I've been there for about 2.5 years now, it's going to 3 years. Let me tell you what we're doing. I'm studying at the far end to better understand these things that are not there that we're trying to do. First, we are completely changing healthcare delivery in Sierra Leone. Completely overhauling the system of healthcare delivery in Sierra Leone. Historically, what you see is disease-based interventions. Have a malaria program, funded. You come in and you have a malaria program going. I have a cardiovascular program. Somebody dumps some money in there, you have a program there. I have a TB program, there's a program. It's completely incoherent and responding to the funding agency or the funding interest. What we're doing now in Sierra Leone is completely reinterpreting universal health coverage, where all 7.5 million people in Sierra Leone, their healthcare matters. And the way we're doing it is looking at life stages, starting with the pregnant woman. What services, what programs, what care do we have for the pregnant woman to ensure that the pregnant woman remains healthy and delivers safely? So it doesn't mean that we ignore your malaria program, your cardiovascular, but all of these now are directed at the pregnant woman with two issues in mind. First, a target of a healthy pregnancy, a healthy pregnant woman, and a safe delivery of a healthy baby boy or baby girl. When that baby is born, what do you do for him as a country or her as a country? You look at all of the services and the programs that direct this baby to not only look at survival, but having this baby thrive. And so your malaria program becomes relevant to the baby. The TB program becomes relevant, the nutrition program becomes relevant, the immunization becomes relevant. It's not just workshops and meetings anymore. Its target is driven to this child. Till you get to preschool, kindergarten. What do you need to do for this baby to become really healthy and strong and focus on learning and acquiring knowledge at this critical stage in their life? And so you address the issue of stunting, you address the issue of nutrition, you address the issue of malaria. All these interventions are now directed at this kid. Till they go to school, we're relaunching school health. That's ensuring that all aspects of the child's health are addressed as they focus on learning. Till they go to university, till they're adults, till they're senior citizens. Throughout the life cycle, no one is left behind. You can look at it through a gender lens, you can look at it through a disability lens. We have completely redefined the minimal health care package. Because it's not one size fits all. The pregnant woman's need is very different from the teenager's need, is very different from the senior citizen's need. We're setting targets. You heard that we were able to drop maternal mortality by 60% in Sierra Leone. It is the most performing country in all of Africa. We're better than Guinea, we're better than Liberia, we're better than Nigeria, we're better than Kenya, we're better than so many other countries. So this is our approach, our complete reinterpretation of universal healthcare with targets, with clear goals set. Now, in terms of operationalizing it, there are 4 major areas that we're focusing on. First is primary healthcare. Taking healthcare to the people. I mean, as the doctor was saying just now, you have a situation where if you have a cardiac arrest, if you have an ischemia or something, the diagnosis and the treatment is going to be very, very difficult. Well, we have a mobile hospital system, hospital on wheels that has just nearly everything that you find in a regular hospital: chemistry, biochemistry, hematology, EKGs, all loaded in a bus, going out to the people. We did about 25,000. It's incredible what you find with these mobile buses as you go out to the people. There are communities where over 20% of them have high blood pressure, where 30% have diabetes. Well, are you going to try to address it there, or are you going to wait for the cardiac arrest? Are you going to wait for the kidney failure in a hospital setting? So we're completely rethinking and rejigging the healthcare system. We're taking it to the people on the platform of primary healthcare. We're rebuilding that. The second thing that we're doing is also looking at the hospital systems. Sierra Leone, by the way, is the top-notch country in the world when it comes to primary healthcare, because Marcella Davis actually read the Declaration of Alma Mater 40-some years ago. So for the past 40 years, we've invested nearly all of our resources in primary healthcare. Right now in Sierra Leone, you have nearly 1,600 facilities spread out. If you look at the scattergram of the country, 85% of the population have a health facility within a 5-kilometer radius. Our challenge now is, how do you bring quality to these facilities? And our quality falls in 4 main dimensions. Physical infrastructure, ensuring there's water, there's electricity, that the place is clean, it's tidy, it's inviting for people to go there. Second, we're also looking at staffing and staffing complement, not only the staffing complement in skill set, but also an attitude that you're looking at service to the people. Third, ensuring that you have the right equipment and supplies in there. Fourth, ensuring that you have the drugs available. So we have a deliberate overhaul and relook at primary healthcare in the country. The second thing we're looking at, I told you there are 5 major things we're looking at. The second thing we're looking at is referral networks. How do you get proper referral from the secondary facility to the from the primary healthcare to the secondary and tertiary facility? We're working aggressively on that. It's not only the ambulances. There's a whole administrative structure around the ambulances that we need to take care of. But the relationship between the provider at the primary healthcare unit and the provider at the secondary and tertiary facilities. We haven't invested enough in the secondary and tertiary facilities over the years. My primary responsibility is not to diminish our investment in primary healthcare, but to complement it with some of the new investments that we have in hospitals at the secondary and tertiary level. So we have 17 districts in the country. Each of them has a hospital. Some of those hospitals were built in the 50s and in the 60s. Some of these hubs, Kenema, Port Loko, McKinney, secondary hospitals, they're also covering as provincial hospitals. Bo Hospital was built when you had close to what? 30, 40, 50, 60,000 people. I was born in Kenema, I grew up in Kenema. I know that for sure, that in Kenema, our hospital there, even though it was a regional hospital, had about 35, 40,000 people to serve. Kenema has like 500,000 people now with the same hospital. So you can't expect the services if you don't have real investment in those hospitals at this point. So what I'm trying to do is to uplift these district hospitals, the secondary hospitals, and create new secondary and tertiary facilities in the country. As we speak, in about 2 or 3 months, would have finished the physical infrastructure of the new Pediatric Center of Excellence at Dembi. As we speak, all the equipment and supplies that will really look at advanced care for children will be available at Dembi. As we speak, there's a similar one in Koidu, where we're working with Project in Health, where we have a $25–30 million program that's going to link with Harvard University and University of Kigali out of Koidu. As we speak this week, the Saudi government is in Sierra Leone, where we got $50 million from them to start a new hospital. We're debating if it should be in Lungi or Kerrytown, you know. I have a vision of building 5 major hospitals in the country, tertiary hospitals in the country. They will be going about $70 to $100 million each. I'm looking for partners around the world. I went to Saudi, I'm going to the UAE, fairly soon to go and raise money for that. I went to Tuba. I don't know if anybody knows Tuba. It's an hour out of Dakar. Yeah. They have a 300-bed hospital there, with angiography, with cardiology, with nephrology. I mean, everything in there. That's what we want to see in Sierra Leone. That's what I want to build 5 of those in Sierra Leone. The medical school in Sierra Leone, there's only 1 medical school in Sierra Leone, yeah? Only 1 medical school in Sierra Leone. We need at least 5,000 practicing doctors in the country to meet the needs for 8 million people. 5,000. Guess what? We have 500. And of the 500, 350 are practicing, 150 are administrators. Commerce has trained 1,500 doctors over the last 30 years. 1,000 of them have been lost to the diaspora and to other places. Some of them may be sitting in here today. But the issue here is we have to do 2 things on the supply side. So what I've done now is I've challenged Professor Uri, who's my predecessor at higher education, and said, look, we can do this. If we need 5,000 doctors and you're turning out 50 a year, how long will it take for you to get 5,000? 100 years, provided nobody retires and nobody gets sick. Yeah. So what we've done is to say, look, let's increase the supply side. So last year, they moved from 50 enrolled to 300 students. This year, they moved to 400 students. Yes. So we want to address the supply side of it. But what we're looking at now is providing doctors in Sierra Leone is not just the supply side. We have to forecast the need. How many in the country? But I'll tell you one thing, the Sierra Leoneans are the smartest that you can imagine. They enrolled in this West African College of Medicine. They're acing all of the classes. We established a new residency program in Sierra Leone, 3 schools, one for medicine and surgery, one for nursing and midwifery, and a 3rd for pharmacy studies. These are enrolling students in West African colleges, and they're acing all of the classes that are there. So the potential is there. So what we're looking at is properly forecasting the need, and ensuring that we're training towards those needs. As you train towards those needs, you want to be sure that you could properly distribute that need so that they're all not sitting in free time. Yeah. And what we want to do is to create incentives for as you distribute them to stay where they're being sent. As I said, I was born in Kenema. I won't tell you what year that was. But I grew up seeing about 5 or 6 specialist doctors in my hospital in Kenema. All the Williams and all these famous names, they're all rotated through there. Yeah. Now you're lucky if you have one surgeon in the hospital. So we're going to change that narrative completely. The other day, in Bo, there were 2 doctors in the hospital here. With the first cohort of students that graduated, we sent 10 doctors to Bo Hospital. 10 doctors to join the 2 that were there. I don't know if you heard that stadium accident, the stadium collapsed the other day. You normally see about 100 patients a day, 150 patients a day. In 1 hour, you had 450 students who were part of the accident. They were rushed to the hospital. Nobody died. They were all managed. So in Bo Hospital now, we have an oxygen factory that's there on campus. We have about 5 major oxygen plants in the country, in Kenema, in McKinney, in Port Rockaway, in 34, in Freetown. We have 11 more coming. So Sierra Leone, everybody is a doctor. And everybody dies and say, no, get oxygen. No, you don't get oxygen. We've taken that off the table. We're producing oxygen on site now. We've got canister cylinders that ensures that even if there's no electricity, there's pressurized oxygen that you could use. We want to be able to move that without the switches. What we're also doing is also opening up opportunities. In Bo, we have a private pharmacy. We changed the system such that private pharmacies could now be established inside the hospital. So instead of going out to the street and buying stuff that you're not sure of the quality, what we've done is engage private sector, including diasporas, to come in there and be a part of the solution. You have stringent rules around what drugs are procured and what the quality of the products are, and there's a price cap on it, but it allows you to be moving from prescription to filling your prescription on site at a reasonable price. So you have these doctors, you have a pharmacy, you have oxygen, you have an incident. It shows how robust the system is. So again, we're working on primary healthcare. It's work in progress. We're working on referral systems. We're also working on secondary and tertiary facilities. We're receiving funding from multiple sources to be able to build some of these facilities. What we're hoping to, I just acquired 500 acres of land halfway between Bo and Kenema. 500 acres. The community donated it. Dembi community donated the land for us. We're going to build a medical city there. So I know that in going to Bo and trying to change the Bo facility is going to be problematic because Bo School is next door. Their facilities cover the whole place. The place is all overgrown now. Bo School and CKC, they have something going, but that's something else. But right now, we talk to Bo School. We're going to look at electrification, energy sources for Bo Hospital, Kenema Hospital, Olajuwon, PCMH, and for Bo, there is no physical space anymore. So we had to go to Bo School, and last week Bo School agreed for us to set a solar field as part of their property to be able to supply power to Bo, so you have uninterrupted power. So I think what I'm saying is, there's a lot going on in Sierra Leone. There is a lot going on. We're setting up, again, young people. Fatu Conte, she's not here, but Fatu Conte she went there as a neurosurgeon residency program. She came back, she's raising money, she's yelling at anybody and everybody who will listen to her because she wants to open a neurosurgery unit in Connaught Hospital. We've acquired the equipment, we've acquired a lot of supplies, and we're moving there aggressively to ensure that this neurosurgery unit is set up there. The other day, we had a team from Spain and Morocco come and join us about another way they're doing it, minimally invasive surgery at Connors. You know, this guy, I mean, a cardiothoracic surgeon was there. They had a completely damaged lung. They had a small incision and took out the whole lung. In 24 hours, this guy was walking around. So that's happening. At Choitrams, you had the same thing. They had laparoscopic surgery going on. So the people, I mean, and doing all of this, the residents are flooding the place. The residents are eager to learn. The residents want to be able to be part of the solution. You've got young, dynamic people who are interested, who are ready to learn, who are ready to engage. And what we're looking for is for the diaspora to go out there and not complain. It's not the best situation. But we're looking at you to come in there to help us change this narrative. And we have a very willing and receptive audience there. And one of the most difficult jobs you could have is going to Sierra Leone to do all of this work. But it's also the most rewarding because every day you wake up, you're making a difference in people's lives. Yeah. So, I am counting on you. I'm really counting on you. And don't underestimate Sierra Leone. Don't underestimate Sierra Leone. All of these specialties, I mean, if you are Sierra Leonean and you're here doing this phenomenal work here, yeah, just know that there are young people who are capable. Let's give them the chance. Let's give them the opportunity. So I'm asking, you know, I mean, when my biggest goal now, yeah, is to ensure that Connaught once again becomes a real tertiary hospital. I'm working to ensure that Olajurin, as we have this new pediatric center of excellence, that you're able to consolidate some of the gains of Olajurin, but also open this new vista. One of the things that we're working on is to ensure that all of these major hospitals in Freetown have a network of services that you're able to manage. Yeah. And we're looking at what do we do up in the provinces. Things are changing. Things are really, really changing. But these things change if you believe in it. These changes occur if you're willing to invest in it. Yeah. I don't want you to go out there and say these people are so poor, they can't do anything, you know, or just give them one stethoscope and you give them whatever analysis machine and stuff like that, you know. That is good. But what these people are looking for is for you with all of the experience to put them on your shoulder to see what's possible. The other day, I think last year, I was sitting there and the German ambassador came in with at the American Embassy 4th of July party, and the German ambassador came, oh, I went to Gambia, you know, yeah, the people were very good. I saw this person, he was digging a well, he's really nice, he's working hard for his family. I love these people, you know, I'm really encouraged to do that. I said, Mr. Ambassador, that is very, very good, but that's not what we want from you. Yeah. We don't want you to tell us what we should be doing. What we want is for you to take this guy and put him on your shoulder and to see what's possible, see what the horizon is, and give them the resources to be able to not only feed himself, but feed his community, become the master farmer in this neighborhood. So let's not have sympathy and whatever for our people. Let's go in there with an attitude that we could change this, with an attitude that we are going to work with you to change the narrative. Wait a minute, if it doesn't happen, if you don't do it, who's going to do it? Yes, a couple of weeks ago, Uganda, again, one of the things that I want to talk to my diaspora colleagues about, I consider myself still a diaspora here, but one of the things I look at what your colleagues are doing. In Ethiopia, the diaspora organized. They organized and built a 300-bed hospital with all the services that you're talking about, Doctor. In Ghana, the Ghanaian diaspora colleagues went out and did something similar there. In a lot of cases, it's not even their money. What they do is they create partnerships to go out there and invest in their country. None of day goes by without me seeing, like what I started saying was a few months ago, a lady from Uganda came to me and said, look, I want to come out here and do some work, yeah? But I'm a businesswoman, you know, I'm looking at health business. What I want to be able to do is to build, I think it was a 300-bed hospital by the beach. But I'm also raising money to have a 1,000-bed hotel linked to it. And I want to do it at Lungi, around the beachfront area. You can't say no to her. You cannot say no to her because she is bringing, it's not her money, but she's talked to the Brits, to the Germans, to the UAE, to the network of friends to come in and invest in healthcare that we could be beneficiaries of. So what I'm asking you to think of is not just what your pocket can afford. As diasporans, open your wings, bring other people together. You can only do so much. But if you attract others, you're able to bring a big enough portfolio to actually make a difference. Other people, healthcare is charity, healthcare is good work, healthcare is support, healthcare is also business. We have 3 clear approaches to this. The government is doing its best in terms of healthcare delivery, but that is safety net for everybody. It's healthcare for everybody. So we cannot afford these top of the line things for everybody. We have to start and get the basics right. At the same time, there are opportunities for people to have services for the middle class. They're paying $2,000 or $3,000 to get on the plane to go to Nairobi or to get to Accra, to get to India for services that could easily be taken care of. If one has those facilities there, we are going to be providing it for close to free to everybody else, but some people could afford to pay for it. Let them have the option. Let's not dumb down healthcare to the lowest common denominator. At the same time, we're not able to provide these services. So again, my parting statement is like the 3 or 4 major things here. We want the diaspora to be actively engaged in medical missions because these are really, really important to make a difference. They reduce the burden and the load on government. You take the services to the farthest reaches of the country. That's very, very laudable, and we say thank you. Please continue to do that. The second is there are opportunities for public-private partnerships, where you could actually go beyond the medical mission and look at permanent solutions that you could bring in there. Pharmacy services, diagnostics, imaging, hospital services, all these things that other people are doing. If you want, you could look at partnerships between the government and the private sector, and public-private partnerships to be able to implement these things. A third area is pure private investment. Get your friends, get your family, get others that are interested in this, bring them to Sierra Leone, and we will work with you. There's an emerging middle class that's able to pay for services. We have an insurance scheme that we're building that should be launched early next year. That's been looking at pooling risk. And by pooling risk, you're able to cover some of the costs that at times catastrophic will lead somebody to be bankrupt. So think about it, medical missions, think about public-private partnerships, think about pure private sector investments, and believe in yourself and believe in your country. I'll tell you, some of the things that we're doing right now are the envy of the continent. This approach that I'm telling you about patient-centered care in looking at the life stages approach. WHO is thinking of adopting it. They're asking, other countries are asking, how do they get involved in something like this? So things are happening. And we want you to be proud of your country. We want you to invest in your country. We want you to believe in your country. In spite of all of the hardships, nobody's gonna fix the hardship if you are not a part of that solution. No. Well, we should not limit ourselves. Please don't limit. Again, sorry, I'll send you some slides to see what's happening in Rwanda, see what's happening in Ghana, see what's happening in Ethiopia, see what's happening in Kenya, see what's happening in all of these countries. Don't think that it's impossible for it to happen here. I went to Rwanda in 1999. When I worked for the US government here, we used to give them about $60 million a year for their HIV program. Last week, Rwanda launched the biggest and the largest non-invasive or minimally invasive surgical training center for the whole continent. Yeah. So we've seen them from back there, how they've catapulted themselves. They counted on the diaspora. They work with the diaspora. They work with everybody else. But if we complain that this is not there, they don't get this, they don't get that, they're not ready for this, and who is they? It's all of us. It's all of us. The reason why I stopped this work to go to Sierra Leone, I was advising people around the continent, around the world, on how to build healthcare systems. And they always say, my friend, where are you from? I said, Sierra Leone. And, oh, Sierra Leone, the country with the highest maternal mortality rate in the world. Now they can't say that. No, now they can't. You know, so it's a gradual process, but we could get this process sped up with ambitious goals. With don't settle for it's okay. Don't settle for it's okay. But please watch other countries. I mean, I unfortunately, I tell everybody that what we're doing is here, I say watch other countries. I really advise you not to watch other countries at all, yeah? Because what the tendency is to gravitate towards the average, you know, all the averages. Let us set our own goals, our own moral compass to see what we want to do as a country. Yeah? And you don't settle for it's okay. It's not okay. It's not okay that we don't have the topmost cardiologists here. A topmost internist here, and we say we don't have that in Sierra Leone. Yeah. The topmost, you go to the UK, you have all these top guys in there. Oh, we don't have it in Sierra Leone. Yeah. We want to change that narrative. Yeah. And we don't want you to stop what you're doing. You can sell that country by still being here. But again, have confidence and faith. There are young people, there's the next generation who's there, who's hungry, who wants to stay there and make a difference. I welcome you to come to Sierra Leone.
Thank you so much, Honorable Dr. Austin Dembi, for the time you've spent with us. And there was